This week on the BackTable podcast.
Fun fact, I treated the first patient with tucatinib when my 12-year-old, I was delivering her, so I can easily know when that was in phase 1 clinical trials. So, we had that in the original HER2 CLIMB trial. We've been talking about trastuzumab-deruxtecan now for several years, but, that's been DB03, et cetera. It's now moving up into earlier lines. We've been talking about margetuximab, some other, HER2 trials, but we really haven't been having changes in the first line, and we really hadn't been talking about maintenance in the first line. That's a foreign concept too. And so that's really what's changing for us. And I think it's exciting, and it's exciting for patients really to think about maintenance as well.
I'm Lindsay Peterson, medical oncologist at Washington University, and I have the privilege today of speaking with Dr. Erica Hamilton, Director of Breast Cancer Research at Sarah Cannon Research Institute. Dr. Hamilton, welcome.
Thanks so much for having me today.
Of course. Yeah, we're going to talk about metastatic HER2-positive breast cancer, where there's no lack of new information to discuss in this space, which is really great for us and our patients. If you don't mind, first, just tell us a little bit, about your path to becoming a breast oncologist and what you find so fascinating about HER2-positive breast cancer.
Yeah, absolutely. I think you're right. This is a spot that we haven't had a whole lot of movement in the first line. And of course, as we often do, it's happening all at once. I am a Chief Development Officer at Sarah Cannon Research Institute, and I am the Director of our breast cancer research program here. I trained at UNC in medical school and then Duke University for fellowship. And I've now been at Sarah Cannon for a little over 13 years. So I'm a Nashvilleian now. We hate bad weather, and this weekend it's going to have snow and ice. And so our grocery stores are sold out of milk and batteries. But I love breast cancer. I love drug development, particularly novel agents. And I find it honestly really encouraging with how much breast cancer has changed over the past decade and a half since I've been in practice. And I often tell my patients that really there's very little that we do the same, since I've been in practice, which is really quite encouraging for patients, I think.
I agree. That's so true. I find myself saying that all the time to patients. This was not even a drug that was available when I started. And that's a really amazing thing, I think, to be able to tell our patients. So I'm in St. Louis. I think we're going to get slightly better weather than you this weekend, although not much. So I certainly empathize with that and the grocery store situation. But let's get right into it. So maybe just a very brief background. I think most people are aware of sort of the evolution of HER2-positive breast cancer. We've come a long way since 1998 when trastuzumab was first introduced. I think we want to talk about a lot of the newer data starting with DB01, but DB09 rather. Is there anything background-wise you want to sort of give us that real brief, 0 to 60, we went from trastuzumab to here where we're talking about the newer studies that came out in the last year or so?
Yeah, I think the Cleopatra regimen, taxane with trastuzumab and pertuzumab, has really been our maintenance standard first-line regimen for quite some time. We have had maintenance in those later line metastatic. We've had the emergence of tucatinib. Fun fact, I treated the first patient with tucatinib when my 12-year-old, I was delivering her, so I can easily know when that was in phase 1 clinical trials. So, we had that in the original HER2 CLIMB trial. We've been talking about trastuzumab-deruxtecan now for several years, but, that's been DB03, et cetera. It's now moving up into earlier lines, and we'll get into that. We've been talking about margetuximab, some other, HER2 trials, but we really haven't been having changes in the first line, and we really hadn't been talking about maintenance in the first line. That's a foreign concept too. And so that's really what's changing for us. And I think it's exciting, and it's exciting for patients really to think about maintenance as well.
Very true. Yes, we see that in other areas, in other diseases, right, with immunotherapy maintenance, things like that. And really nice to be able to take people down a notch, down a level from that more intense chemotherapy that they need in the beginning with those induction phases. So let's get right into it. Let's sort of talk about DB09 and how this is changing the landscape. I think there's lots of things we can talk about here, maybe a quick review of the data, and then we can talk maybe a little bit about the nuances about how we'll be using this in clinic.
Yeah, so DB09 was a straightforward trial. It looked at taxane, trastuzumab, pertuzumab, so that Cleopatra THP regimen, versus trastuzumab deruxtecan in combination with pertuzumab. There was a third arm to that trial, which was trastuzumab deruxtecan alone. We have not seen the results of this mystery third arm of the trial yet. So what we saw was the TDXDP arm versus the THP arm. And TDXDP kind of beat the socks off THP. That did not build in any maintenance. So this really was continue these until progression. And that really was TDXDP. On THP, for a long time, we've been kind of doing 6 cycles or maybe 8 cycles with the taxane. And then we've been dropping the taxane out and continuing our HP. For our patients that are ER positive, we often add endocrine therapy there. I think that's really our standard in the United States. And so we really saw quite significant improvement in progression-free survival. I think quite impressive. But, it did raise that question of, is it appropriate to kind of continue a patient with cytotoxic for years and years, because those patients did so well on TDXDP, but, not FDA approved yet at the FDA, under consideration for DB09. But I think we all probably agree that that's emerging as our new standard in the first line setting.
Absolutely. I mean, the PFS data, I think, is so impressive there. It's really, I think, exciting for our patients. But I think you hit on a couple of the things that everyone's talking about, right? So this was not a maintenance trial. This was treat into progression. And yes, it's a chemotherapy-free regimen, but ADCs are not as easy to tolerate as a lot of our other treatments out there. So question one, what do you think most people are going to do? What are you going to do? And maybe how to differentiate which patients. Who are you going to treat to progression? Who are you going to induce with 4, 6, 8 cycles? And then the whole other question when we talk about maintenance is you have a couple of different maintenance options there, which we'll get to. But maybe just comment on that first part. What are you thinking about inducing with a set number of cycles versus continuing to progression? How are you going to make those decisions?
So I don't know, this may be an unpopular opinion, but you asked for my opinion. I'm not going to treat anyone for a set number of cycles. So I think it's a mistake to extrapolate the THP data and think that a set number of cycles is appropriate for TDXD. When we look at the DB09 data, we saw about double the number of CRs. So, double the percentage of patients got to CR. And I think for patients that get to a CR, those are really those patients that we think about the C word for. Are we curing some patients? Are those patients that may do exceedingly well for really a very long time? And so I wouldn't want to take a patient that really might get to a very deep PR or a CR and just stop them at 6 cycles and go on to maintenance. So I personally think that treating to maximal response is most appropriate. And so that would be my strategy. I'm going to treat patients to maximal response. And I also like this because it's kind of personalizing therapy. And so I'm going to look at their scans, and if they aren't shrinking anymore, that would be the time that I would think about dropping out their therapy. By the books, by being very strict by the trial design, the answer is DB09 didn't test that. We should continue to treat patients. Am I going to do that? No, I'm not. I am going to plan to de-escalate therapy and think about a maintenance strategy really almost universally for most of my patients. I guess I would say, is there anybody that I wouldn't do that for? I think I would do that for patients that really didn't have a response. So if your best response was stable disease and you really didn't respond very well to TDXD, I guess that would be a patient that I would say, ooh, that doesn't make me feel warm and fuzzy. And that's probably not a patient that I would de-escalate and think about maintenance. But otherwise, I would treat to best maximal response. We are going to be trying to put out some data from some other trials like DB03, et cetera, about the average time it takes to get to best maximal response. I think that's a little bit longer than people think it is. We also have a little bit of data that's a little bit longer for patients that also have ER positivity. Probably not surprising, but nice to put that data out there.
Yeah, absolutely. I like that response. I don't think anyone's going to have an unpopular view of that opinion. I mean, I think it makes perfect sense, right? We want to follow the trial as best as we can, but we also want to take patient quality of life into consideration. And with that approach, you're really balancing both. You're not coming up with a set number of cycles. You're looking for that maximal response, which we know, portends a better prognosis down the road. And so I think that that's a very, reasonable approach that I think a lot of people will be interested in taking. I think we have to talk about ILD. We talk about it every time we talk about this agent. I think a lot of people wonder, how often am I supposed to scan? Am I doing high res? Am I doing normal CTs? There are different protocols. A lot of people get pulmonary involved early. We know you can have ILD more than a year out. So these Q9-week scans a lot of people are doing, how manageable is that? Just give us your approach to that, your take on that. How are you monitoring for ILD? How frequently? And is there anything differently you're doing up front proactively for these patients?
I think those are fantastic questions. I really think people are all over the board on this. I hear some people saying, I'm starting to space these out more. I know Dana-Farber is still scanning every 6 weeks, like the clinical trial. I find in the real world, insurance isn't going to allow me to do that. I tend to keep scanning every 9 weeks. I can get scans, on that every 2-month interval through insurance. So I keep my patients there. I find that I really do want to find the ILD at grade 1 because I want to be able to intervene. I typically do put my patients on steroids. I get rid of the ILD and I get them back on therapy. I really don't want to find the ILD when it's grade 2 or grade 3 where I'm supposed to stop drug and I can't get them back on the drug that really is going to provide an overall survival advantage. And so I do tend to stick to those 9-week scans. It is a burden. I think it's the Achilles heel. This is, just what we have to do with this drug. This drug doesn't cause neuropathy. It doesn't cause some of the other things. And I think this is where I've settled out in terms of this drug.
Yeah, I agree. People are all over the board, and it would be nice, if we had some better guidelines. But I think for now, everyone's taking the most reasonable approach, that they can. And sadly, insurance does play a role in this in terms of how often we can get scans for some patients. But let's talk a little bit about maintenance. So there's a couple different trials right here that we should touch on, both for ER positive and for all comers. And we can maybe start with PATINA, talk about that data, and then we can sort of roll that into HER2-CLIMB-05 and talk about what our options might be, when we do decide that it's time to move on and think about maintenance for therapy for these patients.
Yeah, well, this is a timely recording because there's a little bit of breaking news with PATINA. We had some guidelines, NCCN guidelines that came out last week, and PATINA was included in the guidelines. It's been a little bit tough, at least in the state of Tennessee, because we haven't had a publication for PATINA. And so there was quite a lag to actually getting this in the guidelines. So let's go back to San Antonio Breast 2024 when we first saw the data for PATINA. So this was looking at the maintenance setting in the first line. So we already talked about Cleopatra was our standard, taxane, trastuzumab, pertuzumab. And after 6 or 8 cycles, we were dropping the taxane out, continuing our HP. And for patients that had hormone receptor positive disease, we were starting endocrine therapy. And PATINA asked the question, could we add palbociclib, our CDK4/6 inhibitor, and improve PFS for these patients? And it did. And actually, I think we were all really impressed with the magnitude of benefit for PATINA. So PFS was really lengthened, over a year with the addition of palbociclib. Was also kind of nice because it was some great data for palbo, kind of resurrected a palbo in a lot of ways, which I think they deserved that. So for that subset of ER positive, really great data. In Tennessee, we've been having trouble getting this because our insurers were like, we don't have a guideline yet, but we do now. So, I think this was an attractive strategy because this maintenance idea of being able to drop the cytotoxic out and being able to kind of continue on antibodies with endocrine blockade is really attractive for patients. I mean, I think we've all had these patients that have gone on to stay on this type of regimen for years without progression. Eventually, most of the time, these patients do progress, but to be able to have kind of years without having a cytotoxic really is very alluring for patients. Typically, they feel very well, especially with our overall survival, being on average in excess of 5 years for HER2-positive breast cancer. This really gets back to quality of life and kind of trying to think about turning this into a chronic disease for some patients. And I think is a big win in breast cancer.
Yeah, absolutely. And, I think that's really important to point out the survival differences, the improvements that have been made over the last decade in terms of survival with HER2-positive cancer. And we always in metastatic breast cancer have to take quality of life into play, right? But to your point, we're also, potentially curing some of these patients. And so it is a real balance in how aggressive we are with their therapy. Before we move on to the other maintenance trial, we're going to talk about thoughts on palbo versus ribo. I know there's a little bit of safety data from the Korean study with the ribo. Will you stick to the trial? Are there patients for whom you might want to substitute ribo if that's an option for you? What are your thoughts there?
Yeah, I think it's a valid question. I'm kind of a clinical trial purist. I'm going to use palbo. That was the trial that was done. I don't see a big reason to use ribo. We don't have a lot of ribo data with, pertuzumab, et cetera. So I don't think we necessarily probably should really extrapolate into HER2-positive disease there.
Right. Okay. Wonderful. Lots of questions people are asking, right, in the community especially. What are we going to do? People are used to ribo in the metastatic setting. So like you said, this is sort of a resurgence for palbo, and I think it'll take some getting used to for people to be going to that with this particular regimen. But let's talk a little bit about how you're going to make these decisions. So you've got somebody on trastuzumab-deruxtecan. You have treated them to maximal response. You're ready to move on to maintenance. You could argue you could continue the pertuzumab. You've now got PATINA, you've got HER2-CLIMO-5. Are you going to put all your ER-positive patients on the PATINA regimen? How are you going to choose between these?
Well, maybe we should dive into a little bit of the HER2-CLIMO-5 data before we compare. So HER2-CLIMO-5, I presented that at San Antonio this past year, so in 2025. A little bit of a different trial because it included patients that were ER positive as well as ER negative, and asked a very similar question to PATINA of could we add tucatinib now instead of adding palbociclib when the taxane dropped out. Okay, so somewhere between 4 to 8 cycles of taxane. Again, people didn't have progression and added tucatinib or not. Patients could also add endocrine therapy if they were ER positive, and overall progression-free survival was improved 8.6 months with the addition of tucatinib, highly statistically significant. If we broke out the groups of ER positive or ER negative, if the hormone receptor negative patients, on average, the benefit was 12.3 months in progression-free survival, and the hormone receptor positive group, on average, the benefit was 6.9 months. Both of these were statistically significant. So, overall, the benefit was a bit greater for the HR negative, was still positive for the HR positive. There was an exploratory analysis among patients that had brain mets at baseline. This was pretty rare. Again, this was the first line setting. So, brain mets, luckily, are pretty rare in the first line setting. But PFS there intracranially was about double, about 4.4 to 8.5 months. So, not statistically significant, exploratory, et cetera, but, looked pretty good. So, how do we look at that? I think both are reasonable options. Tucatinib, we can see a little bit of diarrhea. Most of the diarrhea comes from the capecitabine. Diarrhea reductions were 6% with tucatinib, 3% with placebo. Discontinuations were very rare, only 1.5%. Actually, more common discontinuation was actually due to LFTs, about 7% of the time. So, different side effect profile, palbociclib or tucatinib. I think both are reasonable. There was a little bit of talk about magnitude of benefit. I think that appropriately came up. The magnitude of benefit was over a year with palbociclib. It was 8.6 months with tucatinib. I think in some ways that was a little bit of an unfair comparison. I think these really were two very different populations. If you looked at the hazard ratio, the hazard ratios were actually very similar. They were essentially 0.74, regardless of what trial you looked at. In some ways, I think the patients that came on with ER-positive disease, they have a little bit more indolent disease, right? And probably, skewed towards a little bit more bone disease, et cetera. Patients that went on to tucatinib probably were a little bit more HER2 driven, a little bit more aggressive disease. And so I think that might influence me a little bit. I think probably most of my patients with ER disease probably would get palbo. If I had somebody with a really high HER2 ratio, a little bit more visceral disease, et cetera, I think I'd probably be swayed more to do tucatinib there. So I don't think it's a one size fits all for me. I think it'd probably be based on that individual disease characteristics, but I think both are reasonable options.
Yeah, I think that makes a lot of sense. And as always, there are gray areas. It's not always black and white. I think patients sometimes are actually surprised by that, right? How many different options we have, and we have to take patient characteristics and side effects and all of these things into account. And I do think it's important, like you highlighted with the tucatinib, most of us are used to using that in combination with capecitabine and trastuzumab, and that can be a very difficult regimen for patients. And so I think it's important that we're not necessarily going to see the same side effect profile once we disentangle that from capecitabine.
Absolutely.
You hit on brain mets a little bit. I think, again, a very evolving field. It's newer to a lot of us to go from primary CNS-directed therapy to potentially considering systemic therapy upfront for some of these patients. So we've got a little bit of data, with brain mets with all of these agents, starting to get a little bit with leptomeningeal disease. Tell me your thoughts on these agents and using them potentially upfront in patients with brain metastases. Who are the patients you might do that? When are you still bringing in local CNS-directed therapy?
Yeah, that's a fantastic question. And I'll say I actually find the data with trastuzumab deruxtecan extremely compelling in brain mets. I feel like, the more we learn in breast oncology, the more we realize we don't understand. I mean, I remember when we used to say on the stage, antibody-drug conjugates are very large molecules. They're not anticipated to get into the brain. I mean, what did we know, right? And now, it's our highest objective response rate in the brain. So, response rates upwards of 70, even 80% in some series. So clearly with brain mets, our blood-brain barrier is disrupted. So TDXD really having fantastic response rates. Now with that, we have the confidence to actually look at leptomeningeal disease. We're seeing good activity there, in fact. So when do I use systemic therapy versus local therapy? I think symptomatic brain mets, those are really where I want to use local therapy. Those patients kind of need a quick response. We need to control that disease, certainly, seizures, that type of thing for sure. Those patients need steroids and local therapy. Asymptomatic brain mets, often with a conversation with the patients, I'll rely on systemic therapy. I often, a lot of times, think about repeated radiation. Often when my patients get brain mets, it ends up still being kind of the rate limiting problem for life expectancy. And so we get into a situation where we end up with brain progression and my radiation oncologist says, I just don't feel like I can treat that area again. And so in some ways, I'm hesitant to pull my card for radiation too early if I don't really need it, because I don't want down the road that to become a problem. And so if we don't have, a symptom, sometimes I'll rely on systemic therapy and kind of hold that card to later. And honestly, I let them see the rad-onc up front and have that be a multidisciplinary conversation. I find that to be extremely effective. I'm curious to see what you say as well.
We typically get our rad-oncs and our neurosurgeons involved, thinking about SRS, et cetera. I think our general approach has also been for the asymptomatic patients where we think about, using systemic therapy upfront. Repeated radiation in patients can be quite detrimental, to their cognitive function, their overall health quality of life. I have patients who have had non-CNS, zero non-CNS disease for 3-4 years, and they have just recurrently progressed in the brain. They have lit therapy, they have SRS therapy. You go through absolutely everything you can. And I've actually had conversations with a couple of these patients, like, should we think about some systemic therapy? This is a data-free zone, obviously. We don't have disease outside the CNS, but you continue to progress in the CNS. Should we consider some systemic therapy in the hopes that we're going to improve, that progression-free survival there? I've had a lot of pushback in patients in terms of side effects in those agents, even tried it in a few different patients with a few different regimens. And I think that can be a difficult thing for patients to wrap their head around. I don't know if you've had any experience, any patients similar where their non-CNS is completely NED, and it has been, but they just continue to recur in the brain.
Yeah, absolutely. And I find those the most frustrating cases, actually. I had a patient who had a PCR to neoadjuvant therapy, and she was on her last cycle of HP in the adjuvant setting and recurred brain only. Like, that's not supposed to happen, but I feel like we keep seeing this more and more now. And so then her course continued to be, only brain disease, right? So I think it's really frustrating. And, that's where I really feel like our trials, she had that PCR, but, there's still these patients that tends to be, where their disease comes back, and it's extremely problematic.
Exactly. Yeah. And hopefully, as we move some of these agents that have more CNS penetration into the adjuvant setting, we'll see less and less of this. So let's talk a little bit about some extenuating circumstances. People love to ask the question, someone's been NED with HER2-positive disease for insert your year of choice, 3, 4, 5 years. Are there patients where you are stopping their therapy?
Well, the first answer is that there are some ongoing trials asking that question, because I ultimately think that we really need a randomized trial to answer that for us. I think it depends on, are they having symptoms from their treatment? Typically if I have somebody that's on like trastuzumab and they aren't having any symptoms, I don't think that, typically if we're going to have heart effects, that tends to happen in the first year. It doesn't tend to happen on that year 3, 4, 5 if they haven't already had it. And so we typically talk about, let's not mess with what's not broken. And we typically continue it. If they're on something like TDM1 and they have cumulative fatigue, et cetera, I don't know that that's worth it. And we do talk about stopping it. I think it really depends on, what they're on. HP, a lot of times we'll stop the P, but maybe continue the trastuzumab. I think it's an individualized decision. It's tough because, you really have to ask the fundamental question of, do you think that they're really cured? And by cured, you think that there's not a remaining cancer cell in their body that's actually suppressed by the therapy, where if you stop it, it's going to come back? Or do you think that they are just treated really well and suppressed? And I don't know that we have a way to answer that question for each individual patient in front of us.
Right. And I think a lot of patients are hesitant to stop for very good reasons, that you just mentioned. I can think of one patient in particular who had a resected brain met, in fact, and biopsy-proven distant disease outside the CNS. And she had been on Herceptin alone for over 5 years and developed what I think truly was an unrelated heart condition. And we stopped her Herceptin, and it's been another 5 years, and she's remained disease-free. But until we know who those patients are, that is a really tough call to make with patients.
Yeah, 100%.
Okay, we can talk about a couple other extenuating circumstances, but before we do that, any other data you want to talk about, maybe some smaller trials, anything else you want to bring to the forefront to make people aware that there is sort of data in progress for some of these areas?
I think maybe something just to touch on is trastuzumab deruxtecan coming up into the curative spaces. We've seen results from DB11 and DB05 this year. So we now have positive data for looking at TDXD in the neoadjuvant space, as well as DB05 in the adjuvant setting. These were presented simultaneously. And so I think we're going to have to make decisions about, do we want to give it adjuvantly or neoadjuvantly? I think there's reasonable arguments for both sides. And then I think the really tough conversation is, what are we going to do for people when they recur and they've already had TDXD? So HER2-positive breast cancer is continuing to change. We've got new agents coming. We have bispecific antibodies like zanidatamab. So you can kind of mentally file this in a bucket, which almost looks like trastuzumab and pertuzumab all in one molecule on steroids, not just together, but additive, because they actually cross-link and kind of almost activate the immune system because of that. The immune system can see that a little bit better with HER2 cross-linking. And that's actually in a neoadjuvant clinical trial right now. So I think that's really exciting. So stay tuned. We're not done. We're aiming to do even better in HER2-positive breast cancer.
Yeah, absolutely. And that's going to bring up the inevitable question of, if someone does recur on TDXD, how long after they complete TDXD are you comfortable treating them with TDXD in the metastatic setting?
Yeah, I mean, I think we'll probably use the old rule of thumb is if it was within 12 months, we'll consider that patient already exposed. And if it's in excess of 12 months, we'll kind of retreat. But, that's just kind of our old rule of thumb.
Now, what do you tell your patients who are newly diagnosed with HER2-positive disease? I think the message we've been giving patients in clinic has evolved over the years as our, overall survival has changed. But do you bring up the C word when you're talking to these patients? Do you reserve that to the patients who have had an excellent response?
I don't bring up the C word initially because I think that not everybody has that prognosis, and it's unfair to dangle that when you're first being diagnosed with what's really an incurable disease. And so I think at first you have to make sure that they really understand what they've been diagnosed with and kind of get them on therapy, make sure that that's all understood. And then you really get more of a gestalt for what their disease is going to look like once you see those first scans and what the trajectory and pace of the disease is going to look like. And then you can kind of refine that a little bit more from there.
Yeah, I think that's so true. I mean, whether it's HER2-positive disease, triple negative, regardless, that's usually my answer to patients is we really have to see how your response is to this first-line therapy to see where you fall in that very, wide prognostic span that patients can be on in terms of their expected PFS and OS. Anything else you want to tell us on the horizon for HER2-positive metastatic breast cancer, or any final thoughts you want to leave everyone with?
Not that I can think of. I mean, I think just to go back to the beginning, so much has changed. If you think about, even just trastuzumab, like you said, in 1998, think about, that we're now in 2026. But if we graph out, our drug approvals on a timeline, it's really been, here in these last few years that things have exploded. We're making good progress. So it's a cool time to be in this field. And I hope everyone's as excited as we are.
It is. It is a very cool time. I agree with that. Well, Dr. Hamilton, thank you so much for joining us on the BackTable podcast. This has been very informative, and hopefully we will continue to see studies like this in the future, and we'll be able to circle back here in a year or so and talk about, additional advancements that have been made.
Thanks so much for having me. Appreciate it.
Of course. Take care.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.